Hello, welcome. We're going to go over musculoskeletal alterations in pediatric health today. By the end of this lecture, you should be able to describe pediatric variations in their normal musculoskeletal functioning and also be able to plan nursing care for children who have musculoskeletal alterations, including hip, foot, and spine deformities, recognize signs and symptoms of infectious musculoskeletal disorders in children, partner with families to plan care for the child with long-term or chronic disorders, prioritize nursing interventions to promote safety and developmental progression in children with braces, casts, and traction. You will need to review what you remember from A&P on the long bones. There's 206 long bones in the pediatric body. Muscles and skeletal tendons and all of those things are the same as with adults. The type of muscles that we are concerned with are skeletal, smooth muscle, and cardiac muscle. Differences in pediatric bones and muscles are that the bones are more porous and pliable, and so pediatric bones break easier than adult bones, but also they heal faster. And when they do break, because they're they're more pliable, they're sort of like green sticks that when you go to break a stick, it breaks more easily if it's dry. So pediatric bones are more pliable and flexible because they're more like a green stick. When they do break, instead of making a clean break, they sometimes make a long tear where the breakage occurs. Their bones are less dense. And the infant skull, as you already know, has the anterior and posterior fontanelles and also the sutures. So make sure that you review where those sutures are. They are very important for providing for the growth of the jaw and the overall skull as the child's aging, and that is throughout their early years so that they can accommodate a full-size head. Some of the major suture lines in the infant skull that we usually think of are the large suture that goes down the center. That does close by 2 years of age, but as I said before, the ones that are in the jaw area, they do grow in order to accommodate, for example, more adult teeth and the overall growth of the head. So children have the same number of bones as adults do, but they do get longer and they grow in circumference, and they grow from the epiphyseal plate down. And so one other difference is that the ligaments and tendons are stronger than the bone itself until they reach puberty. One key thing that you're going to want to take note of for pediatric differences is the epiphyseal plate here. That is where pediatric bones, if the epiphyseal plate remains open, then it continues to grow, and then it stops growing when it gets chemical signals from the brain that the child's entering puberty, and so then that epiphyseal plate will close, and different things can cause that to close early. Other things that can happen are if we have breakages that cross the epiphyseal line, that can also interfere with growth, and we'll talk more about that in another slide. But make sure that you do review this part of the anatomy. Make sure you do go over this again as well to refresh yourself on abduction, adduction, pronation, supination, and those kinds of descriptions of the surface of different surface areas and movements that the bones can make as the child's moving. Remind yourself what RICE stands for, which was the rest, ice, compress, and elevate. So make sure that that extremity that has a suspected injury is elevated above the level of the heart. Also, make sure that you review the 5 P's, which pertain to neurovascular checks. So the 5 P's, again, are pallor, pain, paresthesia, paralysis, warmth, and edema to the area. And those things may indicate that there's possible nerve damage occurring to a limb, and also may indicate a compromised blood supply, which that can quickly become a medical emergency. If you're draining or bleeding from a cast, you might have been told in prior classes that you want to circle that area and then put the date and time on the cast so that we can see if it's stopped or it's getting worse. And then also, when you're caring for anybody with a cast, it's common to have a cast cutter available at the bedside, and that's because a lot of times when a person comes in to have a cast put on after an injury, the limb is still increasing in diameter due to swelling after that cast is placed, and if that swelling is enough to cut off the blood supply distal to that cast, then the cast would have to be taken off. Conversely, if the cast gets loose because the swelling's going down, then it won't be doing its job either. So it's important to do those neurovascular checks fairly frequently when the patient's the first day or two they're coming out of surgery. Checks are usually Q15 to Q30. It varies from hospital to hospital, but you decrease the frequency of those neurovascular checks over time, and that's really the first 4 hours are the critical period where you can have problems with the cast. As you probably remember from your adult classes, you need to cover that cast when the patient is going to get in the shower, or they may get wet. They're not supposed to go in a tub, for example, or the ocean, anything like that. They're not supposed to go swimming, although they do make casts now that are made out of fiberglass, and those are a little bit more forgiving for being wet, but still they're meant to be kept dry. They're never supposed to go in the ocean if they have a cast like that, because even though it's fiberglass, you can get sand up inside there, which can cause pressure injuries. And then, kids are more susceptible to this than adults, I think. It gets itchy as the skin breaks down underneath the cast, and they might want to stick something up there. So very common pencils will be stuck up there, or rulers or something, in an attempt to try to scratch that itch. And the problem with that is that the things can break off and get stuck in there, or they can cause trauma without realizing it. Other things people do, because it starts to smell under there as the skin's being moist for a very long time, people will put powders in there. So they don't want to put powders. You want to instruct families not to put lotions in there or anything. And then kids are famous for sticking toys up in there. Toy soldiers, little race cars, beans, things like that. So parents need to be instructed to pay attention if that's suspected. And then, just overall cast care is sometimes there's edges that are rough, and they can be filed down with an emery board or sandpaper if the edges get rough. So some signs to teach parents to be on the lookout for when a child has a cast are, of course, the drainage. The skin may be broken down underneath there. Any unusual odor that's out of the usual kind of pussy smell or anything like that should be followed up on. If the area distal to that cast is white or blue or cold to the touch, that would be something for them to be concerned about. If the cast becomes cracked or loose, then it's no longer doing its job, and that should probably be recasted. If there's burning, tingling, or numbness distal to the cast, or pain that's not relieved by normal pain measures, or sudden unexplained fever, and they of course have to be reinforced to keep that cast dry. One thing I should also mention is that casts take up to 2 days to dry. That plaster is full of water, and it does get thinner as the water's evaporating out of it, which is good because over those 2 days the swelling in the limb is also going down. So the cast does tend to develop some space in there, and you want to monitor that and make sure there's not too much space. But as it's drying, a lot of times families will try to help it dry faster by putting a blow dryer in there, or a fan or a heater, and that can cause burning. So you want to let them not to do that. And then also, if there's swelling to that limb while it's in the cast, it can, as I said earlier, cut off the blood supply. So you want to, before we cut the cast off, we want to have them elevate that limb to see if some of the swelling will go down with elevation. So when kids wear braces, sometimes they have to wear a brace for, say, scoliosis, or maybe for for club foot, or anything of that nature. Braces you want to treat very similarly to the cast. Children should be wearing a brace for 1 to 2 hour intervals to start. Usually they're a little bit uncomfortable because they're realigning a skeletal misalignment, and so they work up. So they work from 1 to 2 hours, then up to 2 to 4, until they get to wearing it 24 hours a day. And when I say that, they're supposed to have no more than 1 hour off a day. So 23 hours on and 1 hour off. And that 1 hour is really for showering, because you're not supposed to wear a brace in the shower. So the rest of the time, though, they should be getting up to wearing the brace for the full 23 hours. Oftentimes, the brace can be hard or uncomfortable, and so we recommend that if families want to use padding, that they use a white t-shirt or a white sock or some sort of soft white cloth. They do want to make sure that it's not colored, so that you can see if there's drainage or skin breakdown, and also those dyes against the skin for that length of time aren't good for the skin. And they need to make sure that they remove all the wrinkles from the material so they don't cause pressure sores there. And then they need to be aware that when you're wearing a brace for 23 hours, there could be a possibility of pressure sores, so to inspect the skin. So one of the things we want to inspect when we're doing our assessment with pediatrics is, especially in babies, club foot. Most babies have a little bit of clubbing when they are born, the first day of birth, but as they get more and more days out from birth, those feet kind of straighten out. So true club footing is the kind that is not going to straighten out. And so that would be taken care of by surgical methods or serial casting and whatnot, and so that would have to be referred. We also want to notice, as children are getting older, if their knees are what's called knock-kneed, that's when they sort of are turned into to the inside, or they're bow-legged, and that's when they're sort of turned to the outside. And one of the things you want to consider if the child has bow legs is the possibility that they're not getting enough vitamin D, and that leads to a condition called rickets. So most kids have a little bit of knock knees up until age 4, but it should resolve. So this is something that we're concerned if we see it over age 5, 6, 7. So this baby in this picture is wearing a Pavlik harness. And this is one of the early treatments for children that are born with developmental dysplasia of the hips. And this, we may have talked about it earlier in the class. This is where the child's born with their hip not fully, the bone is not fully placed in the acetabulum. And so this should be corrected before the child can walk, because it could interfere with the child wanting to walk, because it's painful to put weight on that hip when it's not in the proper socket alignment. And so this is an example of one of the harnesses that they would wear, and hopefully this is enough to correct it. And children should be screened for developmental dysplasia of the hip up until age 2, because it can be missed. It's not always caught by the pediatrician at the hospital or at the first couple well visits. So it's a maneuver that I recommend that you get familiar with if you're going to work with a pediatric population. This baby is wearing something a little bit more hardcore for correcting the developmental dysplasia of the hip. This is called a spica cast, and this works by, you can see it really holds the baby's legs in the abducted position full time. So the point of this is to make sure that that bone is shifted back into the joint properly and that it stays there. And so right away when you're looking at this picture, you can see the problem with this probably is that it would be difficult to change diapers on this child, and especially if the diaper isn't changed promptly after a stool, this can lead to the diaper overflowing, and that would be a disaster in this case because it's difficult to clean inside there. So it's really essential teaching with this kind of intervention that the parents are instructed to change the diaper frequently and to avoid blowouts. So the Ortolani and Barlow maneuver are also shown here. It's a skill that is not, it takes a little bit of practice to get it right, and so that's why sometimes the baby gets diagnosed later and the early diagnosis is missed, because it's easy to not do this maneuver properly and therefore miss the dysplasia. Now we're going to get into disorders of the feet and legs. So leg calves Perth's disease is a disorder where there's an interrupted blood supply to the femoral epiphysis. The blood supply being cut off causes necrosis to the femoral head, and then remodeling occurs, and that's what we call it when the body removes the necrotic parts of the bone and then tries to heal. And usually it doesn't look perfect when it's healed, and you can imagine that that's a point of articulation, so it could be painful, and so we want to diagnose this early. Late diagnosis can lead to a discrepancy in the length of each leg, so you can have one leg that's longer than the other, or the affected leg is usually shorter. And then it can also cause early osteoarthritis in that bone, because the bone may not articulate back and forth smoothly, which leads to more breakdown. The next one that we're concerned about is the slipped capital femoral epiphysis. And this one can be a medical emergency when this happens. So in this case, it can be a gradual onset or an acute onset, and the sign would be that the child is limping, they have pain in the thigh or groin or the hip, and they don't want to put weight on that leg. And it can occur after a recent growth spurt, because that's when the epiphyseal plate is the weakest. And it can also be caused by children being obese and overweight. It's more common in males than females because of differing levels of activities. But so they're at much higher risk because of extra weight if they're obese. And here you can see this is a picture that's in your textbook, you can see what it looks like. So you have the epiphysis is actually completely out of the socket there. It's not making contact. So it's displaced from the femoral neck at the proximal epiphyseal plate. So this one you may be more familiar with. You maybe know somebody that had this. This is scoliosis. So everybody's spine is a little bit misaligned. Almost nobody is 100% straight. And this gets worse over time, though, as the child gets older. So they may not be that deviated at first, but as they go through their rapid growth of school age, it will become more noticeable. And so if you're up to 10% but not over, that's considered a normal deviation of the spine. And if you're over 10 but less than 20, that's abnormal, but they won't necessarily do any intervention. If it's 20 to 40%, it will require a brace, and like we said earlier, that's 23 hours a day in the brace. And this is an age group where kids, especially girls, don't want to be different, and they don't want to necessarily wear it because they don't want to be noticed. They might wear heavy sweaters in the summer just to cover it up so that it's not noticed. They can sometimes be really embarrassed of having to wear the brace, and it's also uncomfortable. So if it's 40 to 50% or more deviated, surgical intervention is usually required, and they do rods and things to change the adjustment back as close as they can get back to straight. And sometimes, so you would think that they would do the incision through the back, but with some of these cases, the deviation is so bad that they have to do a second or third surgery also to go in from the front to change that alignment as well. And we'll look at some pictures where that might be the case in some of these. But the screening for this, if you'll remember to your middle school ages, that is when this usually becomes more prominent, and we're able to tell if we need to do intervention or not. And so grades 5 to 7 is the common period of time when we will do the screening. And if you remember back to your middle school days when you did this, it's the hands together on the top of the head and dive forward. The feet need to be completely together, and there needs to be no bending in either knee when they're bending over. And then as they're bending over, you would be standing behind them and looking to see if one hip's higher than the other. In this particular picture, you can see that the one hip is definitely higher by the way that the pant line is lower on the left and higher on the right. The other thing that's prominent here is this scapula is bulging out more than the other scapula, and this can be a result of trying to compensate for that deviation, and so you'll see a bulge there. The more deviated someone is, the more of a hunch it can start to look like. And then so kids, especially in this age group, will sometimes go to school with their brace on but take it off when nobody can see, and so they're not always that compliant. The parents need to be instructed to make sure that the child's compliant with this. So this x-ray here on the left is one that I like to show because I like to link different medical conditions to famous people, and it helps me remember. So if you're any kind of history buff, you might know who this is right away. This is King Richard III of England, and he had been in a battle. People were challenging him for the throne, and they had claimed he was a hunchback, and they were making some sort of accusations that made him unfit to be king. But scholars didn't believe it because, first of all, they didn't have the body, to confirm it, and so they weren't sure that it was really true. They thought maybe it was just a accusation that was made against him by his political opponents. Since he did lose that big battle, he was buried in an unmarked grave, and they did recently find his body and verified that it was his, and he did indeed have this really severe curvature of the spine. So this is the type that you would definitely interfere with breathing. So you can see why on this example why you would have to put in rods. And then we want to correct this in teenage years, because again, if you let this go into adulthood, there may not be a way to correct this, because the bones ossify into a certain position, trying to hold that position. Your body tries to help you hold abnormal positions, sometimes by ossifying the bones together, so they can become fused by a natural process. One other thing you can tell from this x-ray that I like a lot is that you can see how they measure how deviated it is. So they draw a line straight up and down. I know my line doesn't look very straight. And then they draw a line this way to show the angle, and then they measure the deviation here. So this angle is more than a 90 degree variation here. So this would have to be corrected by surgery, and we usually want to do this in the middle school to early high school years for the maximum amount of benefit. Torticollis, you can see the baby here has torticollis. This is not affecting the spine. This is actually caused by the sternocleidomastoid muscle here being hypertensed, and treatments for this a lot of times nowadays are Botox injections, so no surgical interventions usually needed for this kind of abnormality. So as a nurse, your job would be to do the screenings that are necessary to catch these kind of abnormalities, also to prevent complications of immobility, complications of wearing a brace or a cast, that would be skin breakdown, assist the child and the family to cope with the treatment plan, and educate them to be compliant with the treatment plan, and facilitate pain control, especially if there's a surgical intervention that needs to be done. So a major concern would be your pain assessment. So the next category of bone disorders that we're going to look at are infections. So you can get an infection in the bone itself or in the joint capsule, and that can affect the musculoskeletal system. MRSA is the most common organism to cause that kind of infection, and sometimes they never know the underlying cause of where that bacteria came from. Sometimes, for example, it is known. So I took care of a child at one point that had osteomyelitis, and they traced it to that child getting a foot injury where they were walking barefoot in a pumpkin patch. And although that they gave antibiotics and the wound healed, a couple months later, the child came in with symptoms of a bone infection, and they found necrosis in the bone related to that infection. So it can be hard to treat with antibiotics because bones are not that vascularized, and so antibiotics are kind of hard to reach into the bone to treat the bone. And it can be hard to get rid of. These infections can also be idiopathic, like they may never find the cause, or they can be something that they got in the hospital. So you're at high risk if there was a surgery on the bone. That can, especially in diabetics that are more susceptible to infection anyways. So if there's necrosis, again, think back to the other slide where I was talking about the effects of necrosis. The bone tries to heal and it doesn't heal properly. That can cause problems. So one of the things that we would do as treatment for this is increase the patient's dietary intake of vitamin C and protein to help heal that bone quicker. Symptoms that the child might present with for this are bone pain, refusing to put weight on that bone, a long time limp, edema to the area, joint pain, fever, and then one of the abnormal labs you would expect to see is, besides white blood cell count, is C-reactive protein and ESR. So they would want to identify the organism, and that could require a blood culture or a bone needle biopsy could be done, depending on how easy it is for them to identify that organism. This slide I included so that you could go over in your mind and you probably already know a lot of this, but the effects of immobilization on the rest of the body symptoms. So even though we're in the musculoskeletal chapter, there is an effect on every other system in the body when you're immobile. And so if you may not have thought about all these different effects thoroughly before, but not only is the muscles affected, so the muscles start to atrophy within a couple days of being immobile, and they continue to lose a large percentage of their mass until the body starts moving again. So that can take a long time to recover from if we immobilize an area. Other things that happen are changes to the urinary system when a patient is immobilized, so they have less urine output. The cardiovascular system is very affected by immobility. The heart actually loses mass as it's adjusting down to the less exercise that it's getting. So your heart muscle actually gets weaker and smaller as it gets rid of whatever it doesn't need if you're not using it, and so it just becomes less effective at pumping blood because it doesn't have to work hard while you're laying down. So that can be something that has to be recovered from afterwards. Also, for children, I want you to think of things that affect them more. As long as they're bedbound or immobilized, they're getting less sensory input, and that can affect their development. You can have confusion, anxiety, stress, and disturbed sleep with prolonged immobility. Of course, you know that the integumentary system is affected because of pressure. But also think of changes to the gas exchange in the lungs. You're a higher risk for atelectasis, pneumonia, and things of that nature. But also the diaphragm becomes less strong because it doesn't have to work as hard if you're not exercising. So everything is affected, and so the longer the child's immobilized, the longer they will have of recovery. And the risk, I want you to also not forget with pediatrics, is in their development. That you wouldn't see that with adults as much, but you'll see that with pediatrics. So this one's a little bit interesting. You usually think of tuberculosis as being associated with the respiratory system, and that's its primary area of concern. But most people don't know, and most nurses don't know this. I know I didn't know this when I was a new nurse, that you can actually get tuberculosis in the musculoskeletal system. I had a patient when I was a first-year nurse, and she actually had TB in her muscles, which was very rare and just very strange. The signs of this is pain, spasms, and muscle atrophy, and if you palpate it, it'll feel kind of like bread dough over that joint or the area where that tuberculosis is. Then there's also infections, like I said, that can get in the joint capsule, and those are very painful. There's a fever, localized inflammation, there's joint tenderness there, loss of spontaneous movement, and the most common joint to be affected is the knee. So other things can happen while the child's having growth and development. So they can be identified as having dwarfism. There's actually two types of dwarfism, and you'll see the one on the left here, the proportions of the body are more or less kind of normal looking from the waist up. And in this case, the from the waist down is where you have disproportion happening. In this one on the right, they are proportional throughout. So this is important because on the left, this one on the left, they have adult size organs a lot of times, and so their lifespan can be severely shortened because of the excess pressure on say the liver and things of that nature. And on the right, they would have less pressure on those particular organs. So this is a lot of times goes along with a prominent forehead. You'll see that as your nursing management, there's self-esteem issues associated with this, and since there's not really a known cure, that you would want to teach the families how to cope with this and how to adapt. A lot of home adaptations are needed. I don't know if you ever saw the TV show about the dwarfs. There was a husband and wife, and I think it was like called Little People Big World. So I don't know if anyone saw that, but it's very interesting. They had all their kitchen cabinets built half size so that they could reach them. They had adjusted their for example, bathroom had to be made half size for them, and even doing things like having a car where it was developed for them so that they could be high enough to see and also to reach the pedals and whatnot. So there's a lot of adjustment that needs to be done, and collaboration with the nurses, doctors, and all the specialists. And also this one is associated with teeth. A lot of people that have this kind of dwarfism have poor dentition, so make sure you examine the teeth with this. This one's very interesting. We actually took care of a child with this diagnosis in the PICU not too long ago. This is called Marfan syndrome, and this chest abnormality is something that you should follow up on right away if you see that. It's called pectus excavatum, and it's spayed off. To me, I relate this, it looks like excavatum, like something's been excavated out of the chest. And then also it could also bulge outwards, so that you could have either one, and that can be a sign that the child needs to be screened for this Marfan syndrome. Marfan syndrome is a connective tissue disorder that causes skeletal changes, and they start off as mild, but they get worse and worse as the child gets older, and eventually lead to a shortened lifespan. Remember that there's connective tissue in your heart, and so a lot of times those things can end up being the reason that there's a shorter lifespan. You can also, as the child gets older and their fingers and toes grow, you can see this extreme lengthening of the fingers and the toes to look abnormal. And a lot of times this is associated with some cognitive changes as well. And so this would be something to screen for, but definitely if you saw this pectus excavatum, that is one of the things that would trigger an assessment. We did have another patient that had pectus excavatum, and they did the tests and they were negative. So it doesn't always mean that they have Marfan syndrome. So nursing management for patients with Marfan syndrome are obviously early identification would be key. Assessment of cardiac functioning is very important. And then teach the use of pre-operative antibiotics, because one of the things they're going to try to do is go in and correct that abnormality to the chest wall. So that would be important. And then also teach them about be a go-between or a liaison with them between all the different specialists they would need to be involved with. So they would not only have a cardiologist, but since this syndrome also affects the eyes because of the connective tissue there, they'll be working with ophthalmologists, orthopedists. They would need genetic counseling in case they want to have more children, or if the child ends up becoming an adult and wanting to reproduce. Osteogenesis imperfecta is an interesting one. The thing I think you should know about this is it's also called brittle bones disease. It's a defect in collagen. And children that have this, a lot of times they present with a broken bone. And you know, it may or may not be considered abuse depending on the age when the child first presents. Even though the bones are brittle, it could have happened very easily and not been abuse. So when the child presents a second or a third time, it starts to generate definite suspicion of abuse if they aren't screened for this particular disorder. And so parents can often be falsely accused of abuse with this. That's a key element to know about this. But along with the soft bones, this also presents with thin, soft skin, increased flexibility, short stature, weak muscles, and hearing loss. So you can also have a blue colored sclera. It's not bright blue, but blue tinged. And nursing management for this is to ask the right questions. Especially, there's a rush to judgment with parents when the child has broken bones. So maybe suggesting this screening could be very helpful in this situation. Talk to the family about coping with this, and again, this is one that's genetic, so genetic counseling would be in order, and also there's a shorter lifespan associated with this. You might, if you're into the Marvel comics or DC comics, whatever, the movies, they made a movie out of this. I think the movie's about Mr. Glass, Unbreakable. Some of you may have heard of it. So I just think that's fun to try to help you remember more about this disease. Muscular dystrophies. Muscular dystrophies are a degenerating disease and a wasting disease. So that means that muscles will become progressively weaker, leading to hypotonia eventually. And it progressively affects all the different systems of the body. And so there's a shortened lifespan with this. But anything, part of your body that has a muscle becomes weaker. And that includes the respiratory, the cardiac, and the bowels. So it's life-threatening, progressively getting worse and worse, and usually ends up being terminal over time. Research is focusing on treating this with, genetic treatment, genetic therapy. It's caused by a chromosomal abnormality, and this is one of those conditions where there's long-term care. So the family usually has a significant burden on them placed having to care for the child, so they may need resources, financial resources, respite care, things of that nature. And then with all chronic illnesses, remember the siblings need emotional support in addition to the parents. So other kinds of things we think about with the musculoskeletal system with pediatrics is kids at least used to go to school with heavy backpacks. So that's something that we would be concerned about, although nowadays a lot of the books are going to online books and it's becoming less of a problem. But also if kids are carrying laptop devices or anything like that, that can also put strain on young kids' backs. Fractures are more frequent in kids that engage in sporting activities. So it's not just football, but it can also be, or let's say baseball or basketball, but it can also be things like horseback riding, or think about kids that are skateboarders or ride the dirt bikes or ski or anything like that. So you want to talk to them about protective gear and safe helmet use if needed, things of that nature. And then I want to make sure that you know what an ORIF is. So when they do an ORIF surgery, that stands for open reduction internal fixation. So when they say open reduction, what that actually means is reduction is when they make the bones come into alignment again. It's called reducing the fracture. And then internal fixation means that they've applied a screw or some kind of device to hold it in place while it's healing, maybe pins. And sometimes you'll see external fixation. So that is when there's needles coming out of the skin and there's an external fixation device. So I just want to make sure you know what those abbreviations mean when you see it. And then, of course, you should know we talked already about casting. So when you're assessing for these disorders, you want to palpate lightly unless you already know it's broken, and then there's really no reason to palpate. But if you are palpating, say there's a suspected fracture, one of the things you're going to feel is crepitus, which feels kind of crunchy when you're pressing on those bones. And so if you felt that, then you would stop because you don't want to cause further pain. And also pain is goes hand in hand with fractures, and so often that will be treated with morphine when that's discovered. So other things you'll see is edema, and then usually if there's a fracture or a break, they can't move the affected limb. So there's immobility. So when you take care of an adult with fracture or a broken bone, you never ever have to worry about if it's going to affect their growth. But with kids, we do. So there's 4 different types of breaks that we worry about with kids. So type 1, it's affecting the epiphyseal plate, but it's a nice, clean, straight break. And so this is not likely to cause any kind of problem with growth. However, the more of the epiphyseal plate that's involved in the break, the more likely you are to have growth disturbances. And so this type 2 one, you can see growth delays are rare. But with type 3, 4, and 5, there's a lot more risk of growth, not only delay, but arrest of growth. And so these are less common, but a lot more frequent to have problems. The 5th, type 5, you don't even have to have a break. It can just be caused by a crushing type injury. So you might see this, say, jumping out of off a tall building or off of the top of a car or something of that nature. And so the epiphyseal plate here is damaged and crushed. And these are rare, but they do affect growth in children if they happen. And I put this guy up here in the upper right hand corner so you can see somebody that was affected by this. You guys probably don't know who this is, but he's a famous artist from the 1800s who had this occur to him simultaneously in both legs from jumping out of a carriage as a child. So he's pretty interesting if you ever want to look him up. There's a movie about him. His name is Tour de Lac. Other things to be concerned about, you may or may not have heard of traction before. Traction is when you lengthen, you put weights on the end of the affected limb to lengthen or straighten the muscles. What happens when you have a fracture or a break is that the muscles around that area immediately spasm, and that makes it hard to get the bone to align properly. And so one of the things, and they used to do it a lot more in the past, I don't see it as often anymore, but they still do this. They put a pulley off the end of the bed, and one side of the pulley is attached to the affected limb. It's usually the leg, and then on the other end of the pulley there's a weight, and it's designed to keep that muscle from hyper contracting. And so as the nurse, your job would be to troubleshoot that, make sure that it's still doing its job. Also, if kids have, they can have traction to the skin, then that is when there's just they haven't inserted any kind of pins for the pulley to pull on, and so in that case it's just the skin that's being pulled by, say, an external brace or something. Though that can cause skin breakdown, so you would be troubleshooting that for pressure points. And then sometimes when there's a break, of course, I said earlier that they can put pins for external fixation through the skin, and so your job would be to try to keep the puncture sites there for the pins clean and as sterile as possible. Of course, it's not going to be perfectly sterile, but you're going to keep it from getting infected. So just as a reminder, when you're taking care of somebody with traction, you're going to check the equipment periodically to make sure that the weight is still doing its job, make sure that it's in the proper position, make sure that the child's body is aligned with that properly, observe the weights and pulleys to troubleshoot any problems, and then if there's anything attaching to the skin, assess the skin for areas of redness, edema, breakdown. Also pins, check them for infection and make sure that they're clean. And then remember your 5 Ps. Check your neurovascular status. So when you're cleaning pins, you'll probably need to put on sterile gloves and do everything sterilely, even though it's on the outside of the body and it's not technically sterile, but we don't want to introduce new bacteria or organisms to that site. When there's traction, the device that's holding the leg in place, that needs to be removed and cleaned periodically. So usually every 4 hours we're performing skin care there. And then if there's any kind of damage to the skin or pressure, we want to reduce that by, you can order sheepskin that we can wrap in that area to prevent some of that pressure. So just as a quick review, going over braces, you want to make sure that they're tight enough to keep the person in alignment, but not so tight that they impair circulation to the skin. You want to check muscular neurovascular status, the 5 Ps, from time to time to make sure that there's no neurovascular damage happening. Usually braces should not be in direct contact with the skin, so you want to pad it with a white cloth of some sort, like socks or t-shirts. And then frequently assess the skin, and they should be on 23 hours a day. Complications of broken bones, I want to mention those really quick also. Infection, of course, osteomyelitis, neurovascular damage is a complication, and fat embolisms can happen. So when a bone is broken, there's bone marrow inside the bone. That bone marrow can get into a vein returning to the heart, and that can cause a clotting event, or so a heart attack or a stroke, something like that. Also, something that can happen, a complication, is if the bones aren't fully aligned, they can heal in the wrong position, and that usually is not caused by you know, the doctor or anybody who's doing the repair. Usually that happens when there's a delay in care. So sometimes you'll see this a lot in kids where they're athletes and they don't want to stop being involved in their sport, so they'll just put off telling anybody that there's a break or a fracture. And that can have serious consequences, because then they have to go in and break the bone and then re-fix it in the right position, which can take longer to heal, and of course it's very painful. There can be length discrepancies after a break, as we went over, so you would want to assess for that, and you do that by having people stand straight with their feet together and again see if there's any difference in the height of the hips, or have them sit, and if you put their legs out straight, they should be even. And then the other thing that we haven't gone over yet is compartment syndrome. Compartment syndrome is anytime there is swelling inside a muscle cavity. As you know, the muscle is inside fascia. The fascia is not flexible, and so if the muscle itself is getting edematous and getting larger from swelling, then that can actually cut off the blood supply to that muscle, and it's considered a medical emergency because you could lose that entire muscle. And this would be something that you might commonly see in a calf muscle or a hamstring or something like that. If you remember House, the TV show House, Dr. House had that. That was why he had his limp all that time. And so it's a medical emergency, and a lot of time they'll just, when the physician comes to the bedside, they'll just take a scalpel and open up that muscle right at the bedside. So the treatment is to just do a long incision down the length of that muscle, and they don't sew it shut. They leave it open for a while till the swelling goes down and then sew it up. So that can mean having this wound open to air for a while. And so that would be something to check for. Usually at the time that I saw this, it was two twin brothers that were doing P90X, and they both came in for severe pain, and they had severe swelling to their legs, and both of them ended up needing emergency fasciotomies to treat this. Okay, and finally, I want to go over quickly another kind of fracture that we see, and this isn't related to a velocity injury. This is related to just being obese, being immobile. As you know, when you're, say you have a very sedentary lifestyle, say you spend all your time sitting in front of a computer screen, there's less muscle mass. There's also less bone strength. And on top of that, kids that drink a lot of soda, soda leaches calcium from the bones over time, and so you can see what's called a stress fracture, and this occurs when they get up and try to be active. They'll have a spontaneous fracture. Also common with kids, of course, sports injuries is a high number of the kind of breaks that you'll see, and then some of these result in amputation. So I think that there's some fun videos for you to look at here. I always show these in class, but you can look at these on your own if you like. They're very interesting to watch, to kind of give you an idea of the interventions that can and should be done as early as possible.